Welcome to this fine Monday evening where we're going to be having an hour talking about the iTrack from Novarai. And today we have two esteemed speakers with me. We have Professor Jose Martinez de la Casa from Madrid in Spain, and we also have Simon Ondrejka from Germany, both very experienced iTrack users, and I'm Leonard from Manchester. I'll just be running the webinar, moderating it, and then maybe answering, asking some of the questions that you have. So if you've got anybody who's got any questions, I'll be grateful if you can put it in the chat, and then we'll look that up, and then we'll ask our speakers regarding all your query regarding iTrack or ab-internal canaloplasty that we're going. So we got a prepared presentation for you guys, and we have two speakers, and we're just going to be literally flying in and out. All the speakers going to be involved, going through the slides, going through some of the data, going through some of the techniques, the patient selection, and so forth. So, hopefully at the end of it, you're going to get a very good idea what iTrack can do, how you should be doing it, what sort of patients, and then any complications that we may have, and any other questions that you may have. So without any delay, I think I'm going to pass on certainly the first 2-3 slides to Simon regarding, I suppose, the main questions. Why are we here?
Hey, good evening, everyone. Simon Ondrejka, my name. I can't see myself. I don't know if there's any video of me, but I want to talk about why I choose canaloplasty, why I choose ABIC. It is, of course, because it addresses all possible points of blockage and resistance of the conventional outflow system. It maintains the physiological integrity. It doesn't destroy tissue. It doesn't need an implant. And the complication rate, of course, is very low, and it can overcome the drawbacks of medications and non-compliance. It addresses 360 degrees of Schlemm's canal. It removes herniated trabecular meshwork tissue from collector channels, which can be blocked by these herniations. It stretches the trabecular meshworks and lowers the resistance of the trabecular meshwork, considering the outflow facility. Okay, next slide, please. We all know that medication is that medication causes large problems. We have multiple drops, multiple substances. We have problems with compliance. We have problems with costs. We have problems with surface toxicity. We have side effects. And in specialty, we have problems with benzalkonium chloride toxicity. And in this picture, we see the surface toxicity, but does it have problems, or does it cause problems with the trabecular meshwork? Maybe as well. There are findings that see apoptosis and the inhibition of mitochondrial oxygen consumption for the trabecular meshwork endothelial cells. So we have to ask ourselves if we are maybe shutting down the pipe of physiological outflow by using medication, and that safe surgery maybe is the better way to go. So next slide is for Jose.
Yeah, thank you, Simon, and thank you, Leon, and thank you, Novarai, for having me in this webinar. And as all of you know, the patients with glaucoma, there is an damage of the conventional outflow system, not only in the trabecular meshwork, but also in the SMS canal and in the collector channels. And in the next slide, I will show you the changes in these three parts of the conventional outflow pathway. And next slide, please. As you know, most of the resistance to the conventional outflow of aqueous humor is in the trabecular meshwork, mainly in the inner part of the Schlemm canal. It's called in the juxtacanalicular tissue. That is a very compact tissue in the inner part of the Schlemm canal. But also there are studies showing that in the patients with glaucoma, there are some kind of blockage of the Schlemm canal. And also there are some kind of blockage of the tissue, as Simon mentioned before, some tissue herniation into the collector channels. The next slide. This is a scheme from the trabecular meshwork, and you can see that compact layer of tissue in the inner part of the Schlemm canal. That is the juxtacanalicular tissue. That is, as I mentioned, the main resistant point for the outflow of the aqueous humor on for the conventional pathway. The next one. And we did some studies a few years ago with prophotometry, and we saw with the trabecular bypass that if we bypass this trabecular juxtatrabecular tissue, we increase the outflow facility of aqueous humor, and the change was really significant when we compare a group of combined SAGE, combined cataract and trabecular bypass or iStent with the cataract alone. You can see 275 of increased aqueous humor outflow in the combined group, compared with only 46% in the cataract alone. And the next slide, please.
Sorry, Jose, was that 1 or 2 iStents, by the way, just out of interest?
It was only one because it was 2010. And it was
wow, okay.
With the first generation of iStent. So it
That's
was
already a significant increase in outflow.
Yeah, it's combined with the cataract, but we see a significant change. But you and I know that in some cases we see a very clear reflux from the collector channels into the Schlemm canal, the blood in the Schlemm canal, showing that the collector channels in the Schlemm canal, it's okay. But sometimes when we try to put the iStent, we didn't see blood at all. In those cases, there could be a collapse of the Schlemm canal or collapse in the collector channels. So it is not only the juxtacanalicular resistance, but also the changes in the Schlemm canal and in the collector channels. The next one, please. Go to the next one.
Yeah, this is the one.
Yeah, no, the next one, please. So that's the changes that I told you. This is the changes in the collector channels when patients with glaucoma with very elevated intraocular pressure. There's some studies showing that in those patients can have a blockage of the Schlemm canal or tissue into the collector channels that prevents the right pass of the aqueous humor into the conventional outflow pathway. Next one. So that's the reason or the rationale for the canaloplasty, as Simon mentioned. So it's a SIA that preserves the trabecular tissue that have an active role in the dynamics of aqueous humor, and it allows to not only to bypass this resistance of the inner part of the Schlemm canal, but also remove any blockage of the Schlemm canal, and as I show you later in this presentation, to increase the size of the collector channels, improving the outflow of the aqueous humor. The next one. So I think it is for Simon.
Yeah. How does ABIC work? So we see here that there's an intubation of 360 degrees of the Schlemm canal. It's a catheterization where the catheter is advanced in the Schlemm canal for these 360 degrees. And in this drawing, we see that the catheter has got a blinking tip, which is important to know where your tip is. And the catheter is already retracted for maybe 3 clock hours. Leon, could you please show, no, go back, please. Could you please indicate with your mouse the area where, at this quadrant, you see that the catheter is already retracted and there is a dilation of the collector channels in this quadrant. And please remember these net-like structures, because I will show you later in my video that one can see them in the human eye as well, and not just in this drawing. And the second part of the action is the viscodilation. Next slide, please. Here we see a close-up again of the catheter inside the canal. The catheterization itself breaks adhesions of the canal. It breaks tethering of the juxtacanalicular tissue, and it separates the herniation we have seen before. And next slide, please. The viscodilation dilates the collector channels, it dilates the Schlemm's canal, and it creates focal disruption of the trabecular meshwork. So all 3 stages of outflow resistance are treated by this viscodilation. Next slide, please. This is how the tool for ABIC looks like. It's the iTrack Advance, and it is not a new catheter, because the catheter we have been using since 2008. And what is new and was introduced 2 years ago is this handpiece. So the catheter is known, and we have very successfully used it for 16 years, because in our practice we have been doing viscocanaloplasty since the catheter was available 16 years ago. This is what it looks like. We have a cannula spatulated tip for easy access of the Schlemm's canal. We have a nozzle which can be turned, and we can turn the cannula in each direction you want to have it for your better working position, and you can use it with your right hand or with your left hand as well. It depends on you how you turn the nozzle. And there's this sliding actuator which is used for advancing and retracting the catheter. And you can forward this slider with one of your fingers, and I usually use my index finger, and it's such nice and precise work that I don't even have to re-grab in most cases. In most cases, advancing with my index finger is enough to get 360 degrees catheterization, and then you don't have to re-grab, and your surgery is faster. Next slide, please. This is a close-up of the catheter itself. I have been talking about the illuminated tip, and beside the illumination, this catheter, which has 220 micron outside diameter and is 45 millimeters long, it has working canal which can be used as a delivery of OVD. So it's the only device that offers a pressurized delivery system for viscodilation. We get 360 degrees catheterization in a single movement, flexibility to titrate OVD volume based on the patency of the Schlemm's canal, and it has the capacity to deliver basically as much volume as the surgeon wants to, but even volumes of 100 microliters is not a problem at all. And it's the only device which offers an illuminated tip that provides you security and accuracy, because you know all the time where you are with your catheter tip. Next slide. I think it's for you, Jose, or for you, Leon.
Yeah.
Why don't we, Jose, if you could just talk us, we're going to play this video and I'm trying to mute the sound. And then this is just a surgical video, courtesy of Paul. But Jose, if you can talk us through it, that would be great.
Yeah, I think it's a very nice video. So when I'd say this is a combined surgery, the cataract surgery is always a window of opportunity. Of course, we can do this surgery as a standalone procedure, but the cataract surgery is a window of opportunity. The first step is to do a paracentesis at 4. This is a right eye to have a good orientation to a little bit oblique, to have a good orientation to the trabecular meshwork. Firstly, it's good to test the light of the probe and to see that the visco is going easily through the tip of the probe. And the next step is go towards the trabecular meshwork, depress gently the trabecular meshwork, and go directly with the probe inside the canal. Right? If the probe is in the right position, the catheter goes very easily into the Schlemm canal. As a tip, it's good to orientate a little bit the tip of the piece, the hand piece, a little bit towards up 10 or 15 degrees, and to complete the 360 until we see the light in the opposite part. You can see here also how the visco started to go out the probe, and as we are retiring the probe, the assistant is doing the clicks to deliver the viscoelastic. It depends on the surgeon preference. I deliver as between 36 and 40 clicks to deliver 100 microliters of viscoelastic, and it's important to do in a very coordinated way with the assistant, trying not to deliver all the viscoelastic in the same position, because we can have problems like the estimate detachment. But as I retire the probe, the assistant is doing the clicks and delivering the viscoelastic in the 4 quadrants. So, and that's the final. Of course, you have to be very careful removing the visco from the anterior chamber to avoid pressure spikes. You can go to the next one. This is one of my videos. It's more or less the same. You go with the probe. Sometimes it can be stuck in a collector or something, and in that occasion, it's good to deliver a little amount of viscoelastic to continue with the probe, going a little bit back, and then go ahead again when the Schlemm canal is a little bit dilated. And it's quite easy in most of the cases to go to the 360, as you can see. And again, when we complete the 360, then we remove the probe very slowly, while the assistant is delivering the viscoelastic in the 4 quadrants with the 36 or 40 clicks more or less. We can discuss later the amount of viscoelastic that you guys use in your surgeries, and if you want, you can go ahead with the next video.
Yes, so this is one of my videos, and what I want to show is we use, or in this case I have used a dyed OVD. We dye it with fluorescein, and I inject viscoelastic when I advance the catheter to be less traumatic on the canal. And here I'm already on my way back, and I usually inject 12 clicks on the way in and 12 clicks on the way out. And now the surgery is already finished. It's a combined case as well. And I like not cutting out the repositioning of the head and repositioning of the microscope, so that I know how much time there is left since I went out of the canal. And now you see a channelography. And remember those net-like structures, you can see them here because we have a couple of very nice collector complexes, and we even see areas where there are no collector complexes, which are collapsed. And what we see as well is where Leon just pointed, there's micro disruption of trabecular meshwork, and dyed OVD is pushed out from the canal through the trabecular meshwork into the anterior chamber. Don't be fooled by this large yellow color inside the anterior chamber. Leon, maybe you can point at the large part. Yeah, that's from entering and exiting the probe. So this has nothing to do with trabecular meshwork. Yeah, that's my surgery. Let's go on.
Okay, this is, as I mentioned before, this is a study that Novi has presented at the ASCA in 2000 this year, the American Glaucoma Symposium, showing the different results with different amounts of viscoelastic. You can see on your left, with a smaller quantity of OPD, the complete success was around 30%. In between, with between 40 and 60 microvolts of OVD with an amount of 120, more or less. The complete success was 64%. And in the right, you have a higher quantity or bigger quantity of OVD with worse results than with the previous quantity. So probably the graph in the middle shows the best balance between the efficacy and safety, and you can see the good success of the Saye with this amount of Viscoelastic. Okay. And we can go after with the next one. So this is another video from Olsing.
Okay,
so the different effects of the iTrack Saye. And he's pointed the diameter of the Schlemm canal, trying to show how it's the dilation of the Schlemm canal after the Saye. And we can see in the next slide more clearly. We can go to the next one. The changes in the Schlemm canal compared with the before Saye and after Saye. You can see the difference in the size of the Schlemm canal. If you can point it, Leon, yeah, you have the Schlemm canal before and after the Saye, and also the collector channels. You can see significant changes before and after the Saye. So, as I mentioned before, it's not only to decrease the resistance, even we can see changes in the inner part of the Schlemm canal. You can see more tissue in the image of the left, in the inner part of the Schlemm canal. So we are decreasing the resistance of the inner part of the Schlemm canal. We are increasing the diameter of the Schlemm canal, and we are increasing the size of the collector channels, as Simon saw in the previous video. We can go to the next one. And talking about results, so what outcomes, what results, and what adverse event we can expect with the iTrack advance. This is the result of the registry that Novi has done with the cases operated with the iTrack advance, and you can see the result. The result has been updated in the International Glaucoma Surgery Registry by Kit Barton. We can go to the next one. And you can see here the results, the baseline intraocular pressure of almost 400 eyes was 80 millimeters of mercury, and the final intraocular pressure, although it's only a few eyes that have arrived to the 2 years of follow-up, the final intraocular pressure was around 12 millimeters of mercury, so the decrease in intraocular pressure is quite significant. And the next one is the number of medication. The baseline number of medication was 2, and the mean of 2 medication. At the end of the follow-up, it was only 1, so it's a 50% of decrease in the number of medication. So even with a not very high baseline intraocular pressure, the decrease in intraocular pressure was quite significant, and the reduction of number of medication, burden of medication, was also quite significant.
Here we see different authors and different publications, and they all look at ABIC. And if we look at the columns show the pre-op and post-op IOP, and all publications show large reduction of IOP. The lines show the reduction in medication. And I want to talk about the 6th publication. That's our publication. Next slide, please. It's a 6 years follow-up of ABIC patients, and we have a pre-op pressure of 19.85, and there's no washout, and we have 1.93 meds per eye, and we have 27 eyes included. And for 6 years, we have a stable decline of intraocular pressure for around 5 millimeter mercury. And we have a little bit of rise in the medication, but after 6 years, it is still just half of what it was pre-op. So that's 2 very nice effects of ABIC. Next slide.
Yeah, talking about the safety profile of this SAGE. The first one is the endothelium, because we all want safe SAGEs in terms of endothelial cell counts. We have some problems in the past with other MIGS. So yeah, I think it's important to check the endothelial cell count, and you can see that the changes in the endothelial cell count is almost it's insignificant because with a very small change in endothelial cellularity after the procedure. Of course, we have no device into the eye, so the small loss is only due to the SAGE per se, and not due to any. Or there's no any other further loss due to a device in the anterior chamber or something. The next one. The other adverse events are quite rare, so it's a quite safe SAGE. We have only a few cases. As I mentioned, it's important how to deliver the OVD, because to avoid problems with the estimate, if we deliver all the OVD in one location, we can have problems with the estimate, but it's related with a bad technique. It's not related with the procedure itself. Of course, we can have intraocular pressure spikes if we don't remove the viscoelastic properly at the end of the SAGE. So I think it's quite important to remove the viscoelastic to avoid these pressure spikes. And also we can have some blood reflux in the anterior chamber. So I think it's important to pressurize the eye at the end of the SAGE to avoid this bleeding in the anterior chamber. If we see a reflux of blood in the anterior chamber, I think it's good to put some BSS or air in the anterior chamber, or even again the OVD to pressurize the eye and to avoid further bleeding, to avoid hypemas in the postoperative period. Of course, we have to remove the viscoelastic and to be sure that there's no active bleeding at the end of the SAGE to avoid the hypemas that can be a complication if we don't manage properly the end of the surgery. And the other complication is the pressure spikes. But again, if we remove the viscoelastic properly at the end of the surgery and we pay attention to that, probably the incidence of the pressure spikes is quite low. Next one, please. So talking about safety, I think the canaloplasty is a safe procedure. And as I mentioned, we have to pay attention to the possible pressure spikes, removing all the viscoelastic and the epimas, the high epimas, because if we permeabilize the Schlemm canal and the collector channels, we can have reflux from the episclerapenos. So it's important to pay attention at the end of the surgery and pressurize the anterior chamber to avoid. And again, the descemet detachment can be easily avoided with a good surgical technique, and other complications are really, really rare. Next one.
So let's come to the patient selection. Of course, glaucoma severity, our standard patient for ABIC would be a moderate glaucoma, early or moderate glaucoma, and with or without cataract surgery. It depends on the patient and on you. Both is very easily possible. Controlled versus uncontrolled. Uncontrolled could be the pressure or the toxic effect of medication, and we are able to get an uncontrolled stage into a controlled stage by performing ABIC. Other considerations, sometimes you or we use ABIC for terminal glaucoma cases as well, because there's no other option. There's no option because of general general health state of the patient. There's no a longer procedure possible, and maybe because of blood anticoagulation, we have no chance of performing other glaucoma surgery. And even in these cases, the results are very good. Next slide, please. So mild to moderate glaucoma is our usual patient selection. Patients that have, of course, long-term prognosis of their living. Healthy angles are important, and open-angle glaucoma, which shows a non-compliant patient or intolerancy to the medication, and of course pigmentary or pseudo-exfoliative glaucoma is treatable as well. Failed iStent or hydrous implantation could be treated by ABIC as well. And it is definitely my first line MIG option prior or after SLT, because it's a very effective and safe procedure, and I don't need any implants and I don't do any destruction, and still have a great effect. So thank you very much.
Thank you, guys. It's a lovely presentation actually by you two, and then timing is great. We have about 25 minutes, so it'll be good to actually go back to go through. I mean, you guys have highlighted many great points and a lot of things we want to dwell into. We've got some questions on the chat, but if we literally go right back where we've started off in terms of the mechanisms of ABIC and the anatomy of it. And then Jose, you started it off. I'm going to have to ask you. I'm paid here to ask these difficult questions. You already mentioned a trabecular meshwork bypass device. So in terms of MIGS, that everybody understands that we started off with trabecular meshwork bypass device. That's been around for many years, as you and I know. And then there are other big schools that like to remove the meshwork. There's a lot of ripper out there and a lot of stentors out there, while ABIC sits a completely different pathway. You mentioned about all the pathway it addresses, but I'm keen to know in terms of what's your feeling about the function of the meshwork and ripping of the meshwork. I mean, it seems to be people are quite happy nowadays ripping the meshwork, and I have my own view on it, but I want to know what you think about what the meshwork is for and whether removing it is a great idea.
I think if we can preserve the tissue, I think the tissue, the intraocular meshwork is not only a passive filter, so it has an action in the intraocular pressure fluidics. So I think if we can preserve the tissue, always is better than remove the inner part of the Schlemm canal. So of course, we can use the intraocular eye stent, but you know that in some cases, we can no reflux at all in the Schlemm canal. So we are not sure if the Schlemm canal is blocked or we have a blockage in the collector channels. So I think the ABIC combine these three mechanisms. Decrease the resistance of the inner part of the Schlemm canal, dilate the Schlemm canal, and open the collector channel. So I think it's and preserve the tissue. So I think it's a very good option. Of course, it's a matter of preference. There are some surgeons that prefer to remove the inner part of the Schlemm canal, but we have bad experience with the trabecular for a long time. So the results were not good. Only removing the inner part of the Schlemm canal. So I think if we can combine these three ways of action, I think it's a good idea.
It is true, isn't it? I mean, I remember when I first saw the ABIC many years ago, and it is exciting that this is the only time we get to treat 360 degrees. And like you said, if you've got a bypass stent, then you can be a bit hit and miss, depends on where you place it. And we think that we're good at placing it, but this is really the only thing that whenever you see that catheter comes round and dilating the canal. I suppose my question, people always ask me that a bit of dilation, how long would that last without stenting? What do you think?
Yeah, we don't know. Of course, it's a difficult question because Simon has long-term studies showing a good maintained effect during the year. So I don't know if you have checked the Schlemm canal with anterior OCT or something.
Yeah, Simon.
Yeah, that's a very nice question I get often as well. And I started asking the contact question, how long do you think it has took for the Schlemm canal to collapse? Because I think it took your whole life.
Yeah.
Or at least many years or many decades until glaucoma developed. So why shouldn't it take as long to work when I dilate?
I think that is a lovely way to look at it. I mean, you're correct that most patients don't develop glaucoma suddenly over a year or two. And how convinced? I mean, you show in the video. How convinced are you that we are overcoming some trabecular meshwork resistance with the dilation?
I usually what I cut out in this video is I start sucking out the OVD with the blue filter on. And so I see that usually when I dilate 360 degrees, I see 360 degrees coming, dyed OVD coming to my aspiration probe. So I know that I have a migration of OVD through trabecular meshwork 360 degrees. So I'm quite sure that I have micro ruptures, of course.
So if we go a little bit about the design of the handpiece, and there are people who wants to know a little bit more about surgical technique, which will come into it. Jose, I mean, people already asked in terms of there are other ab internal dilation technique and devices out there, and How important is it for you to have that illumination? I mean, this catheter, Simon said, has been around since 2008. And it hasn't changed. It's attached to a light box with a flashing light. How important is that flashing light for you?
I think for the surgeon it's quite important to know where the probe is, because sometimes we can see how the probe is in the collector, is stuck in the collector channel, or is even in the suprachoroidal space sometimes if we have no proper technique. So I think it's quite important to see the light or how the probe is going through the 360, or if it's a stack, as Simon says, the levers on Viscoelastic trying to progress, or we can go in the other side with the probe, or do a paracentesis in the other part and go to the other 180 degrees. So I think it's quite important to avoid complications and to try to complete the complete procedure.
Yeah, so I'm just going to echo what Jose said for anybody who haven't seen it, and we've all done it. You can see when you see the flashing lights going around and they come back round, it could happen literally in 10 seconds, and it is extremely slick. And there'll be the odd patient when their anatomy is a bit strange when they started going around and then it goes off radially, and we think that's probably go into a collector channels or go into a suprachoroidal space. And I presume that, Simon, you've had that too when it goes around. Not very often, but it goes off. When that happens to you, what is your surgical tip if that happens?
My tip? First, go back where the deviation happens and give a few clicks there. That sometimes is enough to keep the catheter in the canal. If that doesn't work, I switch my hands. And I have already paracentesis ready in that position. So I just enter the probe and I use the same opening of trabecular meshwork, and I do the probing from the other direction. And in most of the cases, I achieve a 360 degrees probing of Schlemm's canal.
And Jose, someone was asking that you described it before, but if you can go through with us again in terms of how do you get the probe in the canal in terms of the angle of attack at the meshwork?
Yeah, the angle of attack is quite important. So it's important to point a little bit up 10 or 15 degrees. So that's with any technique. We did with a hydrous. We have done with another interno Canaloplasties. So I think it's important to point a little bit up and depress a little bit the trabecular meshwork, introducing the probe in the Schlemm canal. Because if you have an important resistance, probably you are not in the canal, so you have to reposition a little bit. And because when the probe is inside the canal, as you said, it's only a few seconds to achieve the 360 degrees.
Yeah, so when you advance, it is normally very slick, isn't it? If you hit any resistance, then you really should stop, and then maybe a click or two. And then often you can advance easily. If you're trying to push it, then you could bend the fiber optics and then you will lose the light. So I think that's an important tip. We've already mentioned clicks and the amount of viscoelastic that's being used, and we've seen various data. And this is fascinating because, again, we're not the only we're not the only ABIC procedure and device. And the amount of viscoelastic that we're delivering now is quite substantial in terms of amount of clicks. Do you guys think the amount of clicks makes a big difference? Because, you know, we're talking 4 or 5 clicks per clock hour now.
Yeah, definitely. I think that volume is the key in this kind of surgery. If you are not able to deliver enough volume, you will not have the effect you want to have. That's my opinion.
I mean, this registry data that you see is quite telling, isn't it, Jose? That it looks as though there's a sweet spot somewhere in the middle of the number of clicks, which is now what we recommend, which is what we do in the trial, in terms of giving about 100 to 165 microliter. I mean, that's 10 times more than what some of the competitors are doing. And that seems to be a sweet spot that gives us the best success. But I'm going to challenge, wondering, do you think this data is true? Do you think that people may click less because it was a mild glaucoma, and then they click more because it's an advanced glaucoma? So then the one that they click more have a lower success because it's a different patient group?
I react with my clicks because I usually use the dyed OVD, and I directly see what is happening. And if I don't achieve any opening collector channels, I then decide to do more clicks. And sometimes, or the reason why I'm doing it is that I see effect. I see more opening collector channels when I use more OVD, more clicks.
So do you think, I mean, for our audience, 91 of them that's logged in, for people who are starting, would you recommend we vary the clicks, or would you recommend a set regime for everybody?
Good question. I would recommend to do a set regime, because you first need to get used to your gonioscope and to all the handling, and to your co-worker. You know, you need to teach them to react when you tell them, and not do all the clicks at one point. So I would, to those who start, I would say use 24 or 36 clicks, and try to do it in every case.
Jose, would you agree? Is that what you do now?
I agree. I follow the recommendation of Noai with a 36 clicks, so 9 per quadrant, more or less. So because I think it's good to standardize the technique, and my population is always more or less the same. It's mild to moderate glaucoma, usually with a combined. So I prefer to use always more or less the same number of clicks, more than variating depending of the stage of the patient, because it's usually quite homogeneous.
Yeah, so I think that's probably a good message for everybody who's starting or about to start, that I think we will recommend the standard sort of 3 clicks per clock hour. And then that's what I've been doing. That's what we do it in the trial currently, Jose, as you know. And then we're doing 1 click per clock hour going in, 2 clicks per clock hour coming out. But at least it's a set amount of viscoelastic being used. And it is a significant amount already. And I think I'm always impressed in terms of the complication, which is extremely low. And you look at the registry data, it is low. You know, people always talk about that you may strip the decimate. Actually, for me, I mean, the rate is low. I mean, you look at here, we're talking less than 1% of patient, right? Do you have any tip to not have that happening?
No.
But I think Jose mentioned that in terms of that.
Of course, don't apply all the clicks in one point. Apply the clicks only when your catheter is moving. But still with this, and as an experienced surgeon, you still can get those problems. But it's very, very rare. Sometimes it's just the anatomy of the patient is so weak that you get decimetrolysis. But you get trouble with decimetrolysis when the anterior chamber is not filled with OVD. But we are talking about up interno use, and the anterior chamber is always filled with OVD, and the decimetrolysis, they are very, very small. So usually you can't see them the next days, and they disappear on their own, and they don't worry me, actually.
I think that's true. I mean, I've certainly had them. And I think you highlighted that the main point is the fact that we do need to make sure that the anterior chamber is firm. So I'm a massive user in Helon GV, really some cohesive viscoelastic to make sure that your chamber is firm, especially when you're starting off. By the time you finish fiddling around, the AC will have gone a bit softer. And that may be one of the reasons. And the second thing is that you do have to keep the catheter flowing when you inject. Otherwise, you stay still, like Jose said, 2-3 clicks in one place. And you're right that some patients, the decimates are just so much easier to come off. And we see that with phaco wound as well, right? Sometimes you get a flap of decimate, people who's got a tiny bit of fuchs. So, but the risk is very low. And I've never had anybody had any side effects from a little bit of decimate detachment. I mean, Jose, have you had any that
No.
it's worry you at all?
I use also Hilon GB or Hilon 5 to fill the anterior chamber, and I haven't had any problem related with the decimate. Also, it's good to fill the anterior chamber very well to avoid the reflux of blood from the Schlemm canal if somebody is starting, because with any other mix. So to avoid the reflux of blood into the anterior chamber, because if you have blood, the visualization is much worse, and you can have more problems. So that's the other reason to have a very wide anterior chamber, very pressurized anterior chamber.
And I think that's probably why that our complication rate is low. And I think it's certainly one of the slides to say that when Simon said this is probably the first mix he would consider, and I think there's some logic being that this may be the first mix you would consider, because this is really restoring anatomy and physiology to the nth degree. We're not removing anything, we're just dilating the canal. So then the safety needs to be there. And then someone had just mentioned that would you try to perform a trabeculotomy with this device? And I think our advice is no, it's not licensed to do so, it's out of license. So have you tried is a different question than should you? And we'll probably say in this webinar that we shouldn't. But I'm sure we've all tried to rip a bit of meshwork with it. But I mean, we're talking ab internal canaloplasty here, so we probably shouldn't. The other question that I get asked quite a lot, Jose, is spike in IOP. That if you're leaving viscoelastic in the drainage system, surely your IOP will be high the next day. Why are we not seeing it?
I'm very careful removing all the viscoelastic. So I spend a few even minutes removing all the viscoelastic, being sure that I have removed the viscoelastic. And you can see pressures of mid-teens or even 20 in a day, but you have no pressure spikes if you are careful removing all the viscoelastic. I don't know if you, Simon, has.
But Simon, that like your fluorescent viscoelastic is completely filled up the collector channels. Why isn't the IOP high?
Why isn't? Yeah, that's the funny thing. That my theory or my expertise is that if you have OVD inside the anterior chamber blocking the trabecular meshwork, then you get OVDs, and then you get pressure spikes the next day. But if you have OVD in Schlemm's canal or in the collector channels, you won't. And that's the funny thing. I think the key factor here is the trabecular meshwork once again.
Yeah. And I think we talked about it in previous webinar as well. I think people always feel that Hilon GV in the eye equals high pressure. And I think that is true if it is in front of the meshwork.
Exactly.
So it can't get past. Once it's past the meshwork, it seems to do completely different things. Are we all in agreement that the ABIC is done with cohesive viscoelastic, Hilon GV rather than Hilon?
Yes.
Yes.
Jose, is that what you use? You don't use ProVisc? I mean, some other make of viscoelastic doesn't fit. I think it's worthwhile mentioning that it doesn't actually fit into it.
Yeah, I use Hilon GV for the dilation of the Schlemm canal and for the whole procedure. I only use Hilon GV, also Hilon 5 for the anterior chamber during the procedure.
So I think that for the last 3-4 minutes, we probably will want to finish off talking a little bit about the results, because that's what everybody wants to know in the chat, and the comparison to others, not just ABIC, but other mixed procedure in terms of results. But I suppose, Simon, I take it that you're pretty convinced about the results, having been a big user over the last 6-7 years. And someone did mention in terms of medication reduction and IOP reduction. I mean, you can see the IOP reduction. In terms of medication reduction, do you think you're getting enough, or particularly the percentage of people that come off medication? Because looking at IOP graph, you can't quite get the sense.
Your question was how many patients do get off medication?
Yeah, do you think is a procedure that can get people off meds?
Yeah, definitely, definitely. But it's like with everything. In some cases, they get low pressure and no medications, and other cases don't. So it's a variety of results you get. Some patients need medication, and some don't.
And I think I will agree with you that if I can just highlight to some of the people looking at these slides, and it's one of my bugbear really, people who don't like mixed procedure would look at your 6-year result and say that your operation has reduced medication by 1, and that's about it. But actually, we reduce it by 1 over 6 years. And during this journey, lots of people were probably off medication for 2 years, 3 years, and gradually gone back on meds. So ultimately, we might have lowered the pressure by 6 and reduced medication by 1. But actually, a lot of these people were probably off meds for quite a significant period of time. And if you wait long enough, you probably will find that most people do go back on medication because everything that we do tends to fail. But the journey is important. A lot of these people with the average age group, may only have 7 or 8 years post-op life left. So I think that results that you see here is pretty good. Like you said, I think a lot of people are off medications. And there was this, how do you think it compares to other mixed procedure, Jose? I mean, you do loads. Just give me a rough impression. I don't want, obviously we don't have any direct comparative data apart from the MAGIC trial that people listening would know that, we are running a direct comparison of internal canaloplasty against the 2 commercially available devices at the moment. So we'll know the results in 2 years. But if your impression, how does it compare to other ABIC or other MIGS?
Yeah, I try to tailor the indication so it's not comparable because my patients probably are not the same. But I think the final intraocular pressure is more or less the same. Probably the only difference is, as Simon mentioned, the time that lasts the effect of the dilation of the canal, the dilation of the collectors. So probably in the short term, there's no big difference because all the mixed procedures, the trabecular mixed procedures, are determined by the scleral expression. But probably how long it lasts, the procedure is the main difference between the canaloplasty and the other trabecular mix.
But how repeatable is this procedure, Simon? You must have repeated some.
Yeah, definitely. I'm thinking about how many I repeated, and with iTrack Advanced, I have none actually. There was no need of repeating one of iTrack Advanced, of my iTrack Advanced cases. So since the last 2 years, I haven't done any resurgeries, but of course, it's very easily possible because everything stays in physiological order. So you can perform the surgery a second time as well. And if you perform channelography, you know what to expect. Because if there are nice collector channels, it's worth trying again. If not, you would need subconjunctival filtration.
Yeah, so I think that I think we've covered many really great points, and it's such a great hour to talk about not only the device but the technique and so forth. I think we are probably going to have to round up, but I will hate for anybody who bother asking us a question without getting an answer. So I'm just going to very quickly go through what's left. Is there any study comparing the effect of ABIC to KDB or Hydrus? I'm not aware of any. Do you guys know any?
No.
No. So Ahmed, I think that's a study for you to do. And then Novarai would be very happy to fund it if you ask them nicely. When do we know is the right time for the patient for canaloplasty? That is a nice question, actually, probably to sum it up. Jose, when's the right time? What would be your ideal patient?
Yeah, I think my main indication is a combined surgery with a patient with a mild glaucoma and a significant catheter with some medication, 1, 2, medication, I think it's a very good window of opportunity. The other indication is the standalone procedure in a patient with mild glaucoma that has some problems of tolerance or problems, compliance problems. So I think it's a good surgery to do also as a standalone procedure.
And just to go with that, particularly in this control group that you said, mild on a couple of meds coming in, after you've done the procedure, what's your standard post-op regime? Do you stop the meds straight away? You keep them on it, taper down? What do you do?
Yeah, I prefer to remove all the medications and to see if the patient needed any medication. I restart it again. But
Yeah.
I prefer to stop it.
I do the same.
And Simon, your patient selection will be similar to Jose, that you think that the mild moderate group is our target audience?
Yes.
And
definitely. But even without cataract surgery.
So I think that's a big difference, right? I mean, we have this, there seems to have a lot of data on standalone procedure that a lot of trabecular meshwork bypass device we don't tend to have. I mean, they weren't allowed to be standalone in the US for a start, while ABIC can be standalone, and there's a lot of standalone data. So that's quite nice. And even the MAGIC trial that we're doing comparing to Omni, it is a standalone. So then we'll get to see some standalone data, which shows the device actually work.
And even in phakic eyes.
Yeah, so I mean, obviously there needs to have an open angle, but in a phakic eye too. And I think that we will probably come to the end, and I think that this is a nice one to finish off from Matt Ronnie, who's posted this. And I think that I would like to get your take that, do you think that doing something like this is just what Keith Barton always say, we're kicking the can down the road, as in, are we just delaying doing a proper operation like a trabeculectomy? And this has always been a criticism about MIGS, that are we just delaying the inevitable? Jose, what do you say to that?
You mean that if this kind of surgery can delay the conventional filtering surgery?
Yeah, I mean, the argument is the fact that you are just faffing around. Why don't you just do a proper operation?
But I think it's good to gain some years or delaying the filtering surgery. Probably could be needed in the future, but if you can delay for a few hours with no blebs related problems, I think it's a good option to have.
Without a doubt, and I will agree with that. And that message for everybody's, that's all we do in glaucoma, is to buy time, you know. So we give them some drops, we do some laser, so then we can avoid invasive surgery, the proper operation, as people like to call it. You know, hopefully we delay enough so then we never need to have it. So I think that's why we're here, interested in some less invasive surgery that we could be done safely and combined with cataract or standalone. So lastly, Simon, any famous last word in terms of, for anybody who wants to start ABIC, what is your best piece of advice?
Yeah, try to use your gonioscope in your daily routine, so you know the angle structure. That's the most important device. That's the most important tip for beginners. Know the anatomy. You will have it much easier when you perform your angle surgery.
And Jose, what's your best tip for me?
I think the patient selection. So avoid, at the beginning, avoid phakic patient. So of course you can do it in a phakic patient, but I think it's much easier instead of phakic patient with a wide anterior chamber with a wide angle, and avoid patient with a antiplatelet to anticoagulants because I think the risk of bleeding is higher. So I think the patient selection, mild glaucoma, patient selection, and pay attention to the remove all the viscoelastic at the end of the surgery to avoid complication, to be sure that you have no active bleeding at the end of the surgery to avoid complications. So I think as my main points.
Yeah, so I think people with high blood pressure who is on anticoagulant, and someone mentioned high episcleral venous pressure, that would be an absolute no-no for this procedure. We've just been asking for trouble. So I think we come to the end. Thank you, Jose. Thank you, Simon, for all your great tips and a great presentation. And thanks everybody for logging in and all your questions. I hope that you go away understanding the mechanism behind ABIC, the design of our device, and how easy it is using the surgery and how low risk really, and be impressed enough with some of the data that's been published. So then hopefully it will inspire you to, if you haven't, go and have a go, start it. And I think hopefully maybe next time we want a webinar, you can come back and tell us your experience. Once again, thank you, Jose. Thank you, Simon. Thank you for Novarai for organizing it. Have a good evening. Thank you very much.
Thanks, Leon.
Thank you.